morning, everyone. Well, it's morning with me. I'm in a small town in Mississauga. It's near Toronto. I had come here at the Toronto University for a small class on public health in Canada for the MLE exams and the Canadian entrance exams. So, anyways, there's a news I think we all know. It's there in Facebook. It's there in WhatsApp that the NEET exam is scheduled on 7th of January, and let's see when the examination papers open and prospectus would come in and things like that, so that we have more details over the examination system that the government MCI is planning. I had a request, coming back to the session today, I had a request from a couple of students regarding infectious disease epidemiology. So they wanted to take up this small topic of infectious disease epidemiology, and I pushed into some infections we will discuss today in the session. So the basic discussion today would be on these topics. So a very easy go ahead that we'll start off with what is sporadic, what is endemic, epidemic, pandemic, point one. Next point would be what is attack rate, secondary attack rates. Next is incubation period, generation time, latent time, serial interval, index case, primary case. So they have a lot of questions on these topics. And one very important topic box I have left out over here is about the carriers, right? So let's get going. Let's discuss these first section, that is what is sporadic, endemic, epidemic, pandemic. So what is sporadic? Sporadic is scattered. Just remember one word, sporadic is scattered. So you can have some cases here and there, you cannot have. It's not necessary to have these cases. Example, in India, we have sporadic cases of rabies. We have sporadic cases of maybe scrub typhus. We have sporadic cases which are here and there. You might get, you might not get. Second point is what is endemic. What is endemic? Endemic is, just remember, it is persistent presence of disease in an area. Persistent presence of a disease in an area is known as endemic. And needless to say, we have a couple of diseases which are endemic in India. Examples are, we can have hepatitis, which is endemic. We can have acute gastroenteritis. We can have various diseases which are endemic. They are persistent presence at a single time in a given defined area. Important to mark is in a given area. So in a defined geographical area, if you have endemic, if you have persistent presence of a disease, that is endemic. Next is epidemic. Epidemic, we all know, is increase in number of cases. But what is this increase in number of cases? Examiner will not ask you what is epidemic and you say that it is increased. That's a very basic stuff. Examiner is not looking for this. Point for you to remember, especially for these DNB and NEET entrance exam. Epidemic. What is epidemic? Epidemic is sudden rise in number of cases. That everybody knows it. Sudden rise in number of cases. That everybody knows. But how much rise? If you have like 20 cases, 21 cases, 22 cases over like 2-3 years, if there is a 28 cases, if there are 30 cases, is it epidemic? Maybe it is an epidemic, maybe it is not. So what is epidemic? It is sudden rise in number of cases which is clearly in excess or which is more than 80% of expected frequency, or which is more than 2 standard deviations. So it is 2 standard deviations more than 80% of the expected frequency. That is known as epidemic. And what is pandemic? Pandemic is over a large area. How much large? Like if it involves one state or one city or one town or one country or one continent, answer is it is one continent. So what is pandemic? Pandemic is when the disease spreads over 2 continents. 2 continents, or we can call them as WHO regions. So whenever the disease crosses 2 WHO regions, that is known as pandemic, right? So that was for the first section. Next is what is attack rate, what is secondary attack rate. Well, before moving forward, I'll just like to have an interim check. Is it everybody? Is it audible for everybody? Is it audible for everybody? Okay. And in case anybody who has a question, you can just type in, and I will take a break after every topic, short break like 1 minute. In that break, we will discuss all the doubts or the questions you want to ask within this small topic. So after every small subtopic, we will take a 1 minute, 60-second break, wherein we will discuss all the questions. So you can keep on asking the questions in the chat box that you have. Next topic we'll take up is what is attack rate and what is secondary attack rate. Well, that's a easy stuff. Attack rate and secondary attack rate, it's not very big thing. What is attack rate and what is secondary attack rate? Attack rate is simple. It is number of cases divided by total population exposed. The point to remember is out of the total exposed population. If, for example, you have 100 people somewhere, 100 individuals are there, out of them, let us say 20 people were not exposed. So the denominator over here would be 80 and it will not be 100. Example, very frequently, the examiner will ask you, calculate the attack rate for a measles outbreak in a village where there were 1,000 children, out of which the measles coverage, vaccine coverage was 20%. Was 80%, let's say. So if it is 80%, so 80% of 1,000, that is how much? 800 individuals were already not exposed. So how many are remaining? 200, out of which there was an outbreak of 5 children. So what is, let us say 5 children were there in a population of 1,000 with 80% coverage. So what is the attack rate? Attack rate would be 5 cases divided by 200 into 100. So that is the attack rate, right? So just remember, it is the number of amount of people who are exposed. Second is, what is secondary attack rate? Secondary attack rate is secondary cases. Out of these 5, what are the new cases? So please remember, secondary cases are number of cases which occur after the primary case. So just remember, it is, I will give you a very simple formula for your exam. Just remember, it is again total number of cases, population which is exposed. So what is this? This is actually the formula for attack rate which I have written, but the examiner is asking you what is secondary attack rate. So what is the difference? It's very easy. Please remember, number of cases minus the primary case minus the primary case. So from the numerator you subtract the primary case, from the denominator you subtract the primary case. That gives us the secondary attack rate. So please remember, don't get confused that you will try to calculate the secondary attack rate by, there's another, people would like to say that I did number of secondary cases divided by exposed population. So in this you might get confused. Please, I would suggest you not to take this formula. Take this formula, take the total number of cases minus the primary case divided by the total population exposed minus the primary case. So that gives you the total secondary cases, right? So that's as easy as that. It is also equal to the total secondary cases. So next we take up is, so that was regarding attack rate. Next we would like to take up is what is index case, primary case and secondary case. It's just a point which is associated with it. So we can just talk on this. What is a primary case? What is a secondary case? What is an index case? So primary case is the first case in the community. Second case is the subsequent cases, MCQ. Subsequent cases within 1 incubation period. And what is the index case? It is the first observed case. So that's as easy as that. MCQ, what is the difference between the primary case and secondary case? Time difference known as. The time difference between the primary case and the secondary case, the first case in the community and the subsequent case in the community, the time difference between them, that is known as MCQ, serial interval. What is serial interval? Serial interval is the time difference between the primary case and the secondary case. It tells you roughly about the extrinsic incubation period or the communicability of the disease. It is a rough estimation of the communicability or the extrinsic incubation period of the disease. So that was regarding the primary case, index case, secondary case, and that's it. So we have Dr. C. Arun Kumar asking about PMR, MMR, perinatal mortality. Well, that's not the part of the topic today. We will discuss this, but nevertheless, Dr. Arun Kumar, we have a special video on this. It is already there in the YouTube, and you can check on that. But anyways, after the session, I would love to take up this topic. I'll like to take this topic in a very short span of time, and let's come back to the about the infectious disease today. So next small thing that we'll discuss is incubation period, generation time, latent period, and serial interval. So what are all these things? So let's just see what do we have. We have incubation period, generation time, incubation period, serial interval, and we had latent time, latent period or latent time. Incubation period is from the entry of the organism, to the first signs and symptoms. What is generation time? Generation time is the entry to maximum communicability of the disease. Entry of the organism to the maximum communicability of the disease is generation time. Incubation period is entry to the first signs and symptom. Serial interval, we have already discussed. It is the difference between the primary case and the secondary case. Latent period is a proxy indicator of the incubation period. It is used for the non-communicable diseases. So non-communicable disease usually have a very long incubation period or a latent period, and we call them a specific name, that is the latent period. So that's about this thing. Next we have is what are the modes of transmission: propagative, cyclopropagative, cyclodevelopmental modes of transmission. So if we talk of the modes of transmission, we can have the first mode of transmission, that is the propagative mode of transmission. So if we have this one vector is there, and if the pathogen comes into the vector and it comes out in multiple numbers, so there is multiplication of this agent. So one came and many came out. So what is this known as? This is propagation. This is P for propagation. Example is P for plague. So example is plague bacilli. The vector in plague bacilli is rat flea, and there's a one microorganism which will come, plague bacilli, and many will come out. Second is cyclodevelopmental transmission. Cyclodevelopmental is, this is one vector and one microorganism will come out, and the same microorganism will come out in a bigger form. So this bigger form microorganism, only one will come out, but in a changed form. So this is change in form. So if there is change in shape or change in form, this is known as cyclodevelopmental. Example is microfilaria. Next is, we can have another type of transmission, that is third is cyclopropagative. So if we talk of cyclopropagative, it is nothing but a mixture of the propagative and the cyclodevelopmental. So there is one vector which is there and one thing comes in, and many things which are there in change shapes. So they'll be like change shape. So this is what? This is change in number and shape is what you can remember, but they'll ask you very frequently. The example of this was asked in DNB, I think last session only. Cyclopropagative, the example is, typically is malaria, where you have gametocytes entering the vector. What's the vector? The vector is Anopheles female mosquito. Female Anopheles mosquito. So that was about the cyclopropagative or the cyclodevelopmental transmission. Next we have is what is antigenicity, infectivity, pathogenicity, and virulence. So what is antigenicity? Antigenicity, it is the ability, antigenicity, it is the ability of a microorganism to induce local immune response. It is the ability of a microorganism to induce local immune response. Next, after antigenicity, there comes infectivity. Infectivity is the ability of an organism to do what? To invade and multiply. So ability to invade and multiply is infectivity. Next comes pathogenicity. What is pathogenicity? It is the ability of an organism to invade, multiply, and cause signs and symptoms. So that is pathogenicity. What is virulence? Virulence is the ability of an organism to invade, to multiply, to cause signs and symptoms, and cause severe disease or complications or death. So that is roughly, virulence is roughly equal to the killing power of the disease. So killing power of disease is roughly corresponding to the virulence. So that was about the virulence and infectivity and anthropozoonosis and zooanthroponosis. What is anthropozoonosis and what is zooanthroponosis? So what is anthropozoonosis? What is zooanthroponosis? So what is anthropozoonosis? Anthropo means man. So it is an infection of the man from zoo animals. Very frequently, you go into the exam and you commit this small error. Zoonosis, it is basically a zoonosis. So it is from animal going to man. Zooanthroponosis, it's a disease of animals. Going to animals, from whom? Anthroponosis, it is man giving rise to a disease in animals. So man giving rise to a disease in animals is cattle TB, tuberculosis in cattle. And what is anthropozoonosis? You have many anthropozoonosis wherein like you have plague, you have rabies, you have leptospirosis, which we will discuss right now. So anthropozoonosis, all these things are anthropozoonosis, going from animal to man. So no confusion over this. What is source, what is reservoir, and what is a host? Last point before we take up the infections is what is source, what is reservoir, what is source, what is reservoir, and what is a host. What is a reservoir? Reservoir is a place or a habitat in which an organism lives, and multiplies. So what is a source? Reservoirs are usually the sources, but they may be a source, they may not be a source. What is a source? Source is any place wherein the organism lives. It may or may not multiply, but it spreads, lives, and it spreads to other people. So source is basically a source, and host is wherein the organism lives, multiplies, and infects. Infects means cause signs and symptoms. So host could be like, there are especially for Japanese encephalitis, you have an amplifying host, you have a maintenance host, you can have a dead end host wherein the host is not able to spread to other people. So these type of hosts are there, but more importantly, you need to remember what is a source and what is a reservoir, right? So any questions on these basic stuff? Any doubts, anything you want to ask on this basic stuff? Right. So we move ahead. Secondary attack rate. We have Dr. Darshan for secondary attack rate. Secondary attack rate. So secondary attack rate, what are the secondary cases? Secondary cases are nothing but after secondary cases arising after one incubation period from the primary case. Secondary cases are arising after one incubation period from the primary case. Actually, there's some issue, maybe, Dr. Arindam. I'm not able to understand what you have typed in because it's like kind of a mirror image to me. I don't know. It's a bug maybe in the software. So what I can suggest, Dr. Arindam, is that I'm not able to understand what you have typed in actually. So I think it's the mirror image of what you have typed actually. It's source and reservoir. Something about source and reservoir. Can you just message it to Mr. Rukinder, who's taking care of the technical aspect of this, so that he can just SMS me or WhatsApp me on, or he can type maybe for you, because everybody else I see is in a proper sequence. Yours is in a mirror image. I'm seeing the words. So, anyways, you can. I'll talk about this maybe, Dr. Arindam, at the end of the session. So let's continue with this. Next that we have in line is, after pentas, we have something about the carrier stages. So I wanted to discuss about the carrier states. This is one of the very important slides that we have, and very frequently we have a couple of questions on this. So if you have, or if you can grab a pen and paper, I would sincerely suggest you to at least remember the healthy carriers. Carriers are two important MCQs you get on carriers. One is, frequently you've been asked about what are the healthy carriers. So if you have a pen and paper, I would suggest you to please write down polio, typhoid, cholera, diphtheria, meningitis. These are the typically asked questions from the healthy carriers. Which of the following are the healthy carriers? So there's one question on healthy carriers. Second, there's another MCQ, small MCQ on, do we have carrier stages in measles? Answer is no. Do we have carrier stages in malaria? Do we have carrier stages in gonorrhea? Answer is yes, and answer is yes. So if you can just see over here, gonorrhea, malaria, meningitis, typhoid, dysentery, HBV, we all know, and gonorrhea. So these are all, they have been previous years MCQ. I've just gathered all the MCQs from last around 10 years. They've asked these questions. All of the following show convalescence phase except, so there was polio in this. So polio does not have a convalescent carrier. But I think out of 8 out of 10 questions on carriers, they had been always on the healthy carriers. So I sincerely suggest you to please remember what is healthy carriers. And a small third question, what is a subclinical case? What is a subclinical case? A subclinical case is a person who arises from a healthy carrier. NEET or your All India exam, I think recent question. So arising from a healthy carrier, subclinical case, measles, malaria, gonorrhea, these have, like measles does not have a carrier stage. Malaria, gonorrhea have a carrier stage. Healthy carriers are list you need to remember: polio, cholera, typhoid, diphtheria, and meningitis. Carrier, healthy carriers. So you have the slide in front of you. Can you see them? Polio, typhoid, cholera, diphtheria, and meningitis. So it is polio, typhoid, cholera, diphtheria, and meningitis. These are the list of healthy carriers. Right? So please remember this. This list is particularly important. So that was one question about the carrier stages. So next, let us come to leptospirosis. Let us have a brief discussion about, actually, I have just gathered about a few diseases, around 3-4 diseases. I'll just take a couple of minutes more from you to discuss few diseases which are particularly important and not subclinical cases, but just subclinical cases, they arise from healthy carriers. Subclinical cases, they arise from healthy carriers. So examples of healthy carriers, we have already discussed: polio, cholera, typhoid, diphtheria. Polio, cholera, typhoid, diphtheria, and meningitis. So these were the subclinical cases. They arise from healthy carriers. Healthy carriers, the list was shown to you. So now I have chosen a few diseases. I would not like to name the diseases right now because these are some infections which you normally tend to forget to revise, actually. So that's the reason I don't think I'll discuss over here tuberculosis or malaria, because everybody studies them, right? So I'll be discussing 3-4 important questions from some diseases which I would not like to disclose right now. We'll discuss them. This thing is not visible to you, slide. I've shown a carrier stage slide. Okay. Is it visible now? So I think you would not have seen this then. Polio, typhoid, cholera, diphtheria, meningitis. These are you need to remember these: polio, cholera, typhoid, diphtheria, and meningitis. Can you see it now? Is it visible? Okay, good. So thanks for your information, Dr. Darshan. Polio, typhoid, cholera, diphtheria, meningitis. These are the healthy carriers you need to remember. Please remember, these are the healthy carriers you need to remember. From the chronic carriers, please remember, I think we have had a talk. Malaria shows chronic carrier. These had been questions in the past. I just gathered all these questions together from the past 10, 11 years. And I wanted to see that how many questions were coming on carrier states, because there were a couple of questions I used to see every year they used to ask. So you can just hang on this slide and it will be helpful for your exams. So polio, typhoid, cholera, diphtheria, meningitis is what you can just cram it up. Polio, cholera, typhoid, diphtheria, meningitis for healthy carriers, right? Is it fine now? So we move on next. And just remember, they had asked this NEET exam, which of the following does not show convalescent carrier? So convalescent carrier, they had written polio into it. Polio is not a line in convalescent carrier. Polio shows healthy carriers. Polio shows healthy carriers, and they have incubatory carriers. They do not have convalescence carriers. So that was a small point I wanted to discuss. Next is leptospirosis. So I wanted to have a small discussion about leptospirosis. So let's take up some infections. Actually, I'm a firm believer that the rule of halves, right? You must have studied the rule of halves somewhere in hypertension or in non-communicable diseases in community medicine. If you talk of the rule of halves, actually, rule of halves is what only 50% of the people are diagnosed who have hypertension, and out of those people who are diagnosed, only 50% they seek treatment, and all those who seek treatment, only 50% are actually being correctly diagnosed. So that was the rule of halves for hypertension, right? Something like this. I have a rule of house for your NEET entrance exam preparation as well. What I have seen over the years is that mostly students do a typical type of mistake every time. So one is you tend to read things which you think is important and you tend to focus much more on that. So most of the times what we read without having an understanding of the examination pattern, what we read, you land up or you end up in studying 50% of the syllabus which was actually not ever asked in the exam, but you always thought maybe it's important, but it was never asked in the exam. And all those questions which are actually asked in exam, you read only 50% of them. So I have this concept of 50-50 kind of stuff in for your MCQ exams. So that's the reason I have chosen some typical infections which you tend to forget or which you tend not to study, right? So let me just take first example, that is leptospirosis. Leptospirosis, first MCQ. It is what? Is it a anthropozoonosis or is it a zooanthroponosis? Well, the answer we have already discussed. It is a disease of the animals. Which animal? So it is, let's first write down, it is an anthropozoonosis. It is an anthropozoonosis. Second MCQ. Which animal? It is a zoonotic. It is a zoonotic disease of which animal? It is commonly found in rodents. It could also be found in wild animals. It could also be found in cats or dogs. Cats or dogs or pets. So it is a disease of the animals in which organ? In the kidneys. So it lives in the proximal convoluted tubules in the kidneys of the rodents, wild animals. And this is one disease which we tend to forget. It is anthropozoonosis. Next MCQ. What is the agent for this? So I'll just take a new board, I think. Leptospirosis. What is the causative agent? The causative agent for leptospirosis is Leptospira. Leptospira interrogans. So this is the causative agent for leptospirosis. Next is this is anthropozoonosis. It affects whom? Who can be the disease people or who can be the host? Second point, the host of this disease are incidental host is humans. Humans are incidental host. What is the source? The source is rodents, and very old MCQ, I won't say it's a new MCQ, rodents, the urine of rodents, the rat urine or the cans which are infected with urine of rat and unhygienic conditions, things like this. And the reservoir is again rodents or animals. What is the mode of transmission? The mode of transmission, it could be two things. You can have a direct mode of transmission or you can have an indirect mode of transmission. Direct is, obviously, it is, indirect is through food or water or fomites contaminated with rodent urine oblique feces. Direct mode is direct entry of the leptospira through the skin. So this is usually direct through skin. Recent 2016 MCQ. Leptospirosis can also be classified into occupational disease. People who are handling rodents, people who are handling a lot of grains, food stuff where there are rodents. So it has been classified as a list of occupational disease. This was 2016 MCQ. So that was the mode of transmission. What is the incubation period? It is roughly around 3 weeks. So it ranges from 1 week to 3 weeks is the incubation period of the leptospira. Next MCQ. We're still on leptospirosis. Next MCQ. What is the clinical features? How do we diagnose and how do we treat? Well, the clinical features has been first MCQ. It is a biphasic disease. So if we talk of the clinical features of leptospirosis, it is a biphasic disease. It is divided into two phases, first phase and a second phase. What is the first phase? The first phase is mild it is mild fever with arthralgia, with myalgia, arthralgia. With myalgia, arthralgia, it ranges from 3 days to 7 days. And the second phase, it is a more severe phase, and there is high-grade fever with lymphadenopathy, with hepatosplenomegaly, with very important two things, with pulmonary organ involvement plus renal. And these are the most common cause of death in leptospirosis 2017, one of the entrance exam. This year entrance exam. Pulmonary infections, secondary pulmonary infections, renal insufficiency is the most common cause of death. Out of this, if you want to choose, I would suggest you to go to pulmonary. Pulmonary is much more commoner than having a renal insufficiency in patients. So that's about the second phase of the severe disease, that is pulmonary infections, right? So you have hepatosplenomegaly with lymphadenopathy with very high grade fever, and this can range from 7 days to 10 days, but of course it is more acute, it is more like severe. And that's about the clinical features. Let's see how do we diagnose leptospirosis. Diagnosis of leptospirosis based on two important MCQs. The first MCQ is there is dark field microscopy. So you can have a dark field examination microscopy. So this dark field examination is not routinely done, it is usually in the first week only. So it is usually done in the first week only. The second and the more commonly done diagnostic test is MAT, that is microscopic agglutination test. Microscopic agglutination test. Microscopic agglutination test is the investigation of choice for leptospirosis, and this can be done up to 1 month as well. So 4 to 6 weeks we can do the MAT diagnostic method. There's another test which can be done, but of course the patients don't present in this very early stage. It is Igm Eliza. Igm Eliza is usually found in, it is usually positive within the first 7 days, first 7 to 10 days. If it's done, we can also go for Igm Eliza, whereas the investigation choice or the best test is microscopic agglutination test, right? So that is about the diagnostic. For treatment, the drug of choice for leptospirosis. The drug of choice for leptospirosis is MCQ1, MCQ2. The drug of choice is penicillin G. The second drug that can be given is doxycycline. People who are penicillin sensitive, or who are penicillin resistant, or they have hypersensitivity to penicillin, or in the cases where you cannot give penicillin G, the drug of choice would be doxycycline. But that's why I told MCQ1 and MCQ2 is the drug of choice. Next MCQ3, there's another MCQ to it. The drug of choice for severe cases. The drug of choice for severe cases, it is cefotaxime or ceftriaxone. So cefotaxime or ceftriaxone is for severe cases, for severe cases of leptospirosis. Otherwise, the drug of choices you need to mark is penicillin G, right? So yeah, it comes under the head of bacteria, yes. So next in line, we have another small topic, that is brucellosis, right? Brucellosis. So let's talk something about brucellosis. Brucellosis. Brucellosis is what you all might be knowing. It is also known as a Malta fever. It is a Malta fever. or undulant fever, or Malta fever, that is brucellosis. MCQ number 1, first point to remember. First point, it is caused by brucellosis melitensis, brucellosis abortus, brucellosis suis, or brucellosis canis. Militanensis, militant, just remember it somehow. Militanensis, militant. It is the most aggressive. It is virulent. Fatal, severe disease, militanensis. Abortus, abortus. So it is aborted, mission aborted. So abortus, you can remember, it is less aggressive. It is less virulent. It is usually there in abortus, is there in cattle. Brucellosis is there from cattle. Suis, just remember again, it is less. Canis is also less. Only one is militant. Militant is one, right? So abortus suis canis. Suis, somehow small word, right? S-U-I-S, Suis. So yeah, it's a zoonosis. And going to man, anthropozoonosis. So I'm discussing all these groups, right? So suis, remember S-U-I-S, pig. So it is from pigs. Suis, pigs. Canis, teeth. Canis, canines. Which are the canines? Wolves. Dogs. Rarest. Suis, abortus is what we are scared of. Militanensis is also there. Militanensis, I forgot to say, it's there in goats. So goats are most virulent, militant, aggressive, virulent. Abortus, abort cattle. Suis is from pigs, and canine or canis is from dogs, right? So that was your first MCQ. Which is this? Brucellosis is basically a zoonotic disease, but it has more important factor which is associated with this, that brucellosis is a very important occupational hazard. It is there in people who are handling these animals. You have seen these animals. Just now we did these animals. You've seen them: goats, dogs, pigs. So they are occupational disease. So this comes under again a list of occupational disease, brucellosis. What is the mode of transmission? So it is again that same story. It could be direct mode of transmission, or it could be a foodborne, or it could be something rare, that is airborne. MCQs on this. Whenever the examiner will ask you about which is the most common mode of transmission, most common mistake done by you as student is that we tend to take to brucellosis. So we think it is milk. Answer is no, it is not most common. Most common is direct. So most common is direct. It is occupational disease. So it is most common is direct. Foodborne, it is via milk ingestion, infected milk ingestion, or dairy products. Airborne is particularly important. It's not very common, but it still has. In fact, one of our colleagues back in India. So one of our colleagues suffered. It's a long time back, around 2-3 years old thing. I'm telling you, one of our colleagues, he was working in lab technician, and he got brucellosis. So this is particularly there in healthcare professionals. So you can remember healthcare professionals, they might be exposed to brucella, people who are handling these things, or people who had these animal houses, and they might land up into this brucellosis. So it's airborne, could be to the healthcare, or it could be occupational as well, to the farmers or something. Foodborne is milk or dairy. Dairy products is like most commonly is the occupation. Direct is most common as occupational. So that was about the mode of transmission for brucellosis, occupational disease, and the types. So let's come to the next topic. In brucellosis, we need to discuss about the clinical features and the investigations. So what are the clinical features? The clinical features for brucellosis, it is fever, plus arthralgia, plus myalgia, plus hepatosplenomegaly, and very important feature is leukopenia. So it is a non-specific feature plus leukopenia is plus a history of occupation of this type is brucellosis. And how do we diagnose brucellosis? It is by blood culture of brucellosis blood culture, or we can have a serology. Blood serology for antigen testing of brucella. How do we treat it? The drug of choice is tetracycline. Now, there was a question on this. Tetracycline is given for how much time? The drug of choice is tetracycline. We know the dose is 500 milligrams, 6 hourly QID. And the drug of the question which was asked is drug of choice is given for how much time? It is tetracycline given for minimum 3 weeks. So this is drug of choice given for minimum 3 weeks, tetracycline QID. And in severe cases, however, this could be your next prospective MCQs. In severe cases, however, the drug of choice remains tetracycline plus we give streptomycin. Streptomycin injection 1 gram intramuscular plus tetracycline is what is given in severe cases. In case the patient has some renal problems where you cannot give streptomycin or things like this, the drug of choice would be third generation cephalosporins plus tetracycline. So that was about the treatment. And there's a small MCQ I would like you. This is a prospective MCQ. Do you know? Can you just guess that where is the Brucella International FAO WHO Center? The WHO Center for Brucella, WHO Center, International Testing Center for Brucellosis, WHO FAO, International Center for Brucella, is located in Izatnagar, Uttar Pradesh. It is located in Izatnagar, Uttar Pradesh, UP. So, so that was about brucellosis, right? So that was all about brucellosis and leptospirosis. Any questions you have, you're most welcome to type them down. Leptospirosis, the DOC would remain as penicillin G. Penicillin is the drug of choice we give for leptospirosis. However, in cases where we do not or we cannot give penicillin G, the drug of choice would be doxycycline. But doxycycline is not the mainstay; it stays as penicillin G. Brucellosis, the drug of choice is tetracycline. Right? So, can just have a look at this small question that I just made through. It was actually change type of version. So a 28-year-old male returned from Peru. Peru is in South America. Presents with complaints of spiking fever since 5 days with joint pains, arthralgia, vomiting, and abdominal discomfort. He was icteric. Probably he was having some jaundice with hepatomegaly and a typical rash on the lower limb as shown here. So what do you think is the most likely diagnosis? So Bartonellosis, Lyme disease, babesiosis, or Q fever. Is it visible now to everyone? Okay, good. So you can just type in your text box like A, B, C, D, or what I'll do is I'll open a poll over here so that you can just type in identify new poll. So we have most of the people who are opting for Bartonella, that is Bartonellosis. Right, good, pretty good. So this is Bartonellosis, and this actually is Bartonellosis. And let's discuss something about Bartonella, or we call it as Oroya fever. Oroya, Oroya fever. So let's have a small thing about Oroya fever. Oroya, Oroya fever. The causative organism, A by E is what I write. I personally like, this is just my own thing. Etiology. The causative organism is Bartonella, Bacilliformis. It is a disease which can be taken up through like Bartonella infection. The clinical features of this disease, it is in two phases. The Bartonella can occur in two phases, acute phase, or we can have a chronic phase. The acute phase is what is blood phase, that is hematic phase. And the chronic phase, that is the tissue phase or the eruptive phase. MCQ. Hematic phase is nothing. Hematic phase is nothing. It is simple fever plus hepatosplenomegaly plus lymphadenopathy. Nothing very special. In this, the patient presents with 3 to 5 days of history of fever, which is not very high grade. It's not very spiking. It's a long-term fever, it's a static kind of fever. With very important, these patients will have abdominal discomfort or they will have some icterus or jaundice. In the tissue phase, this is what we have is verruca. So in the tissue phase, we can have eruptions. These are known as MCQ, very important, verruca, verruga peruara. So verruga or verrucae is what is a rash, typical rash with proliferation of epithelial cells. So this is what the rash was that you had seen on the lower limb. So this verruga, it could be like of three types. You can have miliary, which are very small, nodular, or these are three types. So the verruca can be of three types. You can have miliary, nodular, or muller. Muller is which is more than 5 millimeters. Miliary is 1 to 3 millimeters, and this is intermediate, like 3 to 5 millimeters. So what we had seen was nodular type of eruptions in the lower limb. So that was the clinical features of the chronic phase of Oroya fever, and the drug of choice is chloramphenicol plus beta-lactamase inhibitors, beta-lactams. So that was about Bartonella. Next, we can pick up as, what do you see here? What do you think this is? Can you just type it down somewhere in the chat box if you can? This is a very typical, I've shown you all types of presentations which I've found on Google somewhere, on the Google Images. So these are various type of presentation. On this slide, you can see that there is a central erythema with a marginal, again, erythema with a pellar in between. So this is again same type where you have a central erythematous area. Absolutely right. And with paler and a marginal ring lesion again. So what do you see here? So this type where you have multiple type of things. This you have multiple. So 1, 2, 3, 4, 5. You can see multiple things. So these are all the absolutely right. These are the target lesions. These are typical. These are typical for Lyme disease. Absolutely right. These are typical for Lyme disease. So let's see a few questions upon Lyme disease. Lyme disease, first MCQ, the typical classical, the etiology. Etiology is Borrelia burgdorferi. So this Borrelia burgdorferi is what it causes this Lyme disease. The classical clinical feature is the target lesions, or the erythema migrans. So the target lesions or the erythema migrans is the main classical clinical feature. For Lyme disease, if the MCQ says, for Lyme disease, if the question directly shows you this type of feature and they ask you what is the next step, how do we diagnose? The diagnosis of Lyme disease can be done using the serology, but very important, the rash is typical and diagnostic. So if they ask you what is the next step, the next step is directly treatment. If they ask you how to diagnose, diagnosis is serology. But please remember, don't get confused that once you see the rash, you need to diagnose it. No, rash is typical and it is diagnostic for Lyme disease. So directly you need to go for treatment. The drug of choice for Lyme disease, the treatment, how do we treat Lyme disease? The drug of choice for Lyme disease is amoxicillin or doxycycline. In case of severe diseases, obviously we go with second generation cephalosporins. Our drug of choice remains as moxycycline. There's no need of diagnosis. Directly we go for treatment. There's another specific catch point in questions with Lyme disease. They'll give you a history of a person going to the forest area, or the person living in jungle, or the person living in some areas where you have the vector for this. What is the vector for Lyme disease? We forgot to discuss what is the vector for Lyme disease. It is a tick. It is a hard tick. It is the hard tick is the vector. This is the vector for Lyme disease. Hard tick is the vector for Lyme disease. This is a special deer tick and this is a hard tick. Right. So what's this? What do you think is this one? Any idea? You can just put in the chat box anything that you feel. Yeah, intranuclear inclusions. Yes, absolutely right. So these are obviously not intranuclear. We won't say them as intranuclear. These are intracellular. Within the RBCs, you have inclusions. So whenever within the RBCs we see some bodies and there's a history of fever, let's say that the patient comes with a history of fever as well, and there's some infection to it, right? So there's some infection to it. So if you see a mulberry in a RBC, so this is typically seen as a mulberry or a morula in WBCs, RBCs. So these are morula in WBCs, inclusion bodies with a history of fever, which is spiking. With a history of fever, which is spiking. So morulas or mulberry type of things in WBCs, mulberry, absolutely right. So mulberry type of things. So this is Ehrlichia, absolutely right. So this is Ehrlichia. So let's have a brief discussion about Ehrlichia now. Absolutely right, this is Ehrlichia. So let's have a brief discussion about Ehrlichia now. Ehrlichia, also known as anaplasmosis, also known as Ehrlichia, is one disease which is also known as anaplasma, right? So anaplasma Ehrlichia, it is associated with very important things. It is associated with thrombocytopenia with increased liver enzymes, and with it, especially thrombocytopenia, and it is also associated with leukopenia. On the peripheral smear, we have morula in WBCs. So in peripheral smears, we have specially that is morula in WBCs. And the diagnostic, this is the diagnostic thing. This is the most important diagnostic thing that you find Morella in WBCs. And what is the causative or the vector for this? The vector is again a hard tick. The vector is again a hard tick, right? So in this case, the vector is a hard tick, and in this case, in Ehrlichia, how do we diagnose Morella? And the most confirmatory diagnosis is by PCR. Typically, Ehrlichia or Anaplasma does not show rash, but it has a spiking fever, history of fever, and it is again through the same hard tick. So till now what we have discussed is that there are two diseases which are through hard ticks. The hard tick can lead to Lyme disease or it can lead to Ehrlichia. There's another third entity to it. There's another third entity which is transmitted by this exodus tick. It is exodus ticks. Exodus tick. There's another third disease which you need to remember which is transmitted by exodus tick, that is babesiosis, Babesia. So Babesia is the third disease which is transmitted by exodus tick, and Babesia, if you see, this is the typical presentation in Babesia in the peripheral smear, and it has a very typical presentation of a multi-cross. So it is a multi-cross or very typical inclusion bodies. These are small inclusion bodies that you see in these are various types of presentations I've shown you here, and in these cells. So these are special type of presentation. These are multi-cross type of presentation within the cells, and these are special this thing intraerythrocytic ring forms. So these are intraerythrocytic ring forms that you see in babesiosis. Let's see what are the MCQs we get from babesiosis. Let us see what are the MCQs we get from babesiosis. Three important questions from babesiosis. So three important MCQ. First MCQ, it causes hemolytic anemia. Hemolytic anemia. This babesia is severe in patients with asplenic, in asplenic patients. Why? Because this babesia tends to be severe in asplenic because there is no RBC sequestration from the spleen. So directly, so this hemolytic anemia would be very severe in people with asplenia, and diagnosis is by peripheral smear. Peripheral smear showing the intraerythrocytic ring forms. So how do we treat them? The drug of choice is azithromycin plus atovaquone. Azithromycin plus atovaquone, babesiosis again caused by the hard tick or the exodus tick. Hard tick or the exodus tick, right? So that was all about babesia. What do you think is this? Can you identify the thing in option B? Can you identify the creature in option B? I'll open a polling for you. What do you think is this? Is it a tick or a mite or a flea, a hard tick or a soft tick? Yeah, most of you are saying it's a hard tick, but nobody is going for soft tick, right? And nobody is going for flea. So people are going for mite or for hard tick. Good. So that was absolutely right. This is a hard tick. This is a hard tick. I'll again open the polls for you. We'll again have a polling session now. Right, so most of you, like more than 50%, are saying it is option 1, that is hard tick for option B. Now, just look at the so that was the result of the option B. So most of you are saying about option 1, that is 75% go with option 1, that is a hard tick, and 25% go with the might. That's fine. So now just see the option C very carefully. The option C. What is option C? What do you think is option C? Is it a bug, a louse, a mite, a flea? Right. So till now it is all equal. All absolutely equal. 20% going with option 4, 20% with option 3, and around 10% with option 2. No one going with a bug. Great. So almost everybody has done it. So I'll just open the results to everybody. So you can see that maximum people have gone with option 4, that is the flea. So absolutely right. This is a flea. Absolutely right. This is a flea. Most of the time, just remember it's pretty easy. Mite and ticks, they are like this. Flea is flattened like this. So a long, slender kind of thing is a flea. A flattened kind of thing is a mite. Mite or a tick, right? The difference that you need to remember in a hard tick and a soft tick is on this. The head will be always visible in a hard tick. Remember, hard head. So you will see a head in a hard tick and you will not see a head in a soft tick. So head, hard, no head, soft. So head is hard, no head is soft, right? So that was about a few things. And please remember, hard tick causes babesiosis, hard tick causes Ehrlichia, and hard tick causes Lyme disease. So, well, that was all about this thing about some types of infections or these different types of infections that we sometimes see and we forget and we don't revise for the exams. So, well, that was all for this short video or this short discussion we had for a few infections. Well, just remember that you need to remember them for the exams. Make sure whatever you have written, you keep them safe for your exams. And we'll be coming up with these webinars in future as well. And there are a lot many things which have changed in malaria, a lot many things have changed in tuberculosis, but nothing to worry about. We'll be having these short webinars or these type of video interactions with you all. And now I think it is time to just close it off. Any doubts you have? Any doubts you wanted to share or you wanted to, or any topic if you want me to clarify, we can take up in the upcoming webinars. I'm planning for a webinar on malaria very soon, maybe in a day or so, and then we'll go with tuberculosis. Webinar. There's things which have changed in malaria as well. Wow, Dr. Arindam, whatever you are writing, it's exactly in the mirror image form, right? I need to hang them on the opposite. I need to take a mirror to show me what you have written. I don't know. There's a bug, maybe a tick. Well, so that was all from my side, and yeah, we have a few doubts about natal, perinatal, MMR. Okay. So now I'll take up this small point about MMR, perinatal, and IMR and stillbirths. Although there's a video and all those, the topic of the day has already been discussed. So I would like to thank all the participants for joining us for this video. And I wish you a very best of luck for the upcoming exams. And all those who have some other tasks at their table desk to do, you're most welcome to do that. It was very nice having you here. I'll be discussing about a brief topic about IMR, MMR, stillbirth rates right now, perinatal mortality rate. So all those who have some other important tasks, they are most welcome to do that. And thank you so much for joining us. And I wish you a very, very happy Diwali as well. So I'll just take up this small query by Dr. Arun Kumar regarding perinatal IMR, MMR. So let's see what these things are. So the first thing that you need to remember for your exams is what is infant mortality rate. The second thing that you need to remember for your exams is what is a stillbirth rate, what is a neonatal mortality rate. Third thing you need to remember is what is a stillbirth rate. Fourth thing you need to remember is what is a perinatal mortality rate. And last thing you would like to remember is what is a maternal mortality rate, right? So let's just discuss them. What is all this? What is infant mortality rate? It is number of infant deaths divided by total mid-year population. Infant deaths divided by total live births multiplied by 1,000. Infant deaths, number of infant deaths, ID, number of infant deaths divided by live births into 1,000. What is neonatal mortality rate? It is number of neonatal deaths divided by live births multiplied by 1,000. Neonatal. What is a neonatal period? What is a neonatal period? It is from birth till 28 days. What is the infant period? It is from birth till 1 year. Completed 1 year. And what is a stillbirth? It is number of stillbirths divided by all births. What do you mean by all births? That means it comprises of live births plus stillbirths. So what is stillbirth? What is a stillbirth? Stillbirth is death of a fetus, any death of a fetus after 28 weeks of gestation, or which is after 1,000 grams, or which is after attaining 35 centimeters of crown rump length. So please remember what is a stillbirth. Very important. Frequently asked MCQ from gynae, from community medicine. What is a stillbirth? Stillbirth is a death of a fetus which is after 28 weeks of gestation or after 1,000 grams or which is more than 35 centimeters of crown rump length. This is known as a stillbirth rate. Stillbirth rate is total number of stillbirths divided by all births. Divided by all births. What is perinatal mortality rate? Perinatal mortality rate. Perinatal. Natal means birth. Okay. Antenatal is before birth. Perinatal means around birth. Perimetry. So it is around birth. If this is the natal period, before this and after this, this is known as the perinatal period. So what is a perinatal? It's easy to remember. Perinatal period is like from death of a fetus after 28 weeks through the gestation period and till perinatal, till first 7 days, till 7 days of life. So death of a fetus after 28 weeks or during birth or within first 7 days of life, any death of this thing is known as perinatal death. So what is, how do we calculate the perinatal death? So we can calculate the perinatal death as 4th point, perinatal mortality rate. It is nothing but a stillbirth rate plus early neonatal mortality rate. What is early neonatal? What is early neonatal mortality rate? Early neonatal mortality rate is death of a fetus within 0 to 7 days. From birth till 7 days, that is early neonatal mortality rate. Last is what is MMR? Last is what is MMR? MMR. MMR is maternal mortality ratio. It is not a rate. maternal mortality ratio. What is the maternal mortality ratio? Maternal mortality ratio is number of maternal deaths divided by live births multiplied by 1 lakh. In India, we take it as 1 lakh, but it technically is calculated as per 1,000. So in India, we take it as per 100,000, right? So the number of maternal deaths divided by live births per 100,000, that is the maternal mortality ratio. Okay, so we have a small request by Dr. Meera for sampling. Sampling, just 2 points for you to remember. Sampling can be of 2 types. You can have a random sampling or you can have a non-random sampling. What is a random sampling? Random sampling is which is random, right? So it is a better type of sampling. It is also known as MCQ1. It is also known as a probability sampling. Non-random sampling is a non-probability sampling. So what you need to remember for your exam, probability sampling, examples are first, it is probability or the random sampling. It is a simple random, stratified, or systematic. There's another sampling method which is part of it. You can say it is a part of it. It is known as a cluster sampling. So cluster sampling, it's a big topic. We'll discuss it some other time, but simple random, it's simple MCQ. Last year, NEET exam questions. So what is a simple random? It is a random number table method. Or we can have lottery method. So if you do the sampling by random numbers or through lottery method, it is a simple random. What is stratified? Where you make strata. So I'll take this whole thing, I'll divide into maybe lower class, middle class, upper class. I'll take people from this point. So that is known as a stratified sampling. Stratified is you divide population on a particular variable. Stratified is you divide population on a particular variable and then you pick up the population. Systematic is every nth individual. Every nth individual, you want to take 5 people, 20 people out of a population of 100. So you pick up every fifth person. So that is known as a systematic sampling. Cluster sampling, it is for large population where we want to evaluate a health system or program. So example for cluster sampling is you have for universal immunization programs, you have for national iodine deficiency disorder control programs, you do probability sampling. And for non-probability, you just need to remember anything else is actually non-probability. So just non-probability sampling. Example is convenient sampling, quota sampling, convenient sampling, quota sampling. Then you can have purposive sampling. You can have snowball sampling. All these are actually types of non-probability sampling. Well, that was a brief about sampling procedures that we have. So that was all from my side, and I wish you all a very happy Diwali, and may God give you strength, and may God give you encouragement, and most importantly, may God give you enlightenment to do what is right at this point of time, and give you the path on which you can follow, on which you can walk and lead your way to success. And make sure you don't waste your time. This is the only 2 months, and God has been kind. In fact, I would say that December was the scheduled, everybody was thinking of December, so now we have for January as well. So make use of this November December time, and make sure that you keep on revising everything again and again, And because most importantly, 90% of times the students come out of the exam and say that the most common wrong doing by the students is not that they have studied less. The most common answer people, you all would come out of the exam, and your seniors would have also done this. They would say that I did not revise. I knew the answers, I knew the options, but I did not revise, right? So make sure you keep on revising. Don't increase your syllabus. Just go through my previous videos. You'll understand what I'm trying to say. Don't increase your syllabus. Decrease your syllabus. Decrease the things you need to study. Offload your brains and try to revise more. Don't study everything. That will make you just a confused state. Study very less, but study to the depth of it and try to revise it again and again and again. And stay tuned. We'll have these seminars and these webinars again and again. And it's convenient for me as well. And all the very best for your exams.